Dr. Kiggundu, Spire is my name. I'm a Gynae-Laparoscopic surgeon. Today we are going to talk about the Insufflator and pneumoperitoneum. The Insufflator is one of the most important equipment on the minimal access surgeon's trolley. And the Insufflator does one thing: to give you pneumoperitoneum, to convert the abdomen into a potential cavity to enable the surgeon to be able to operate. So the Insufflator is this gadget you see here. There are different types of insufflators, different makes. This is the Striker we are going to demonstrate here. And what is important is I'm going to give the tips for the surgeons to help you to be able to use the Insufflator safely, to be able to troubleshoot, and to be able to understand the physiology behind carbon dioxide, pneumoperitoneum, and the safety measures, plus the likely complications that can arise out of the insufflation. That is the gist of today's discussion. It is important that if you are purchasing an insufflator, it should be at least more than 40 liters. Do not purchase an insufflator that is less by than 40 liters in capacity, because the higher capacity insufflators are capable of giving you quick pneumoperitoneum, high flow rates, even when you're performing very long surgeries. So the higher the capacity of the insufflator, the better. The other thing you need to know are the safety measures of an insufflator. The insufflator is built, especially the modern insufflators are built with safety modes. And these are some of the safety methods of an insufflator. One, they come with an inbuilt warmer so that carbon dioxide flows through them. It is humidified, it is warmed before it gets into the patient to cause hypothermia. So it is important that the carbon dioxide, which is usually frozen from the cylinder, go through the insufflator, warmed, humidified. By the time it gets into the patient, it is warm enough not to cause hypothermia. The other safety mechanism is that the insufflator dispenses carbon dioxide in pulses. It dispenses in pulses. It does not dispense carbon dioxide in a continuous manner. And this helps to synchronize with the diaphragmatic movements so that it allows the diaphragm and the intra-abdominal pressures to build slowly by slowly. Otherwise, if the insufflator was designed to flow in a continuous manner, it would really provoke a vasovagal reaction due to very quick sudden changes in intra-abdominal and intrathoracic pressures. Those are very important safety measures of the insufflator. And lastly, the insufflator is designed in a way that it detects pressures at the tip of either the varus or the tip of the trocar inside the abdomen. At any given time, the insufflator is able to detect how much pressure is inside the abdomen and adjust accordingly. That means that if you are leaking gas from any of the trocars, the insufflator will keep replacing the gas at the rate at which you're leaking. So it will give you information about the dynamics of the pressure inside the abdomen. And if you have overpressures, the insufflator is designed in a way that it will suck back the gas in order to protect the patient. Because if you have overpressures, then you're likely to compromise the venous return, you're likely to compromise the cardiac output, and you can even get cardiac arrest. So that is how the insufflator was designed, to give you all these protective mechanisms in order to protect your patient during the surgery. Throughout all the invasions, it has always been hard to decide which type of gas will be used for insufflation. So as early as the 1970s, surgeons have been trying to come up with the most suitable gas for insufflation that will easily be tolerated by the patient. Several gases were tried, including helium, air, nitric oxide, and they all failed because they could not meet the criteria and the safety to the patient until carbon dioxide was the breakthrough to using carbon dioxide came up. And the reason is because, one, carbon dioxide was found to be very soluble, and that means that what goes in easily dissolves into the circulation, converted to carbonic acid, and easily expelled through the renals and the lungs. That is one of the benefits. The other benefit is that carbon dioxide is obviously cheap compared to the other types of gases, so it can easily be it's quickly affordable by the patient, and it makes surgery much more affordable because you can use one cylinder for a big number of patients. The other advantage of carbon dioxide, it is less combustible. It is almost non-combustible, and the risks of a fire inside the OR are minimized. So given those advantages of carbon dioxide, surgeons have zeroed down to using it for minimal access surgery. Carbon dioxide comes in a cylinder, packed and compressed into a vapor-like state, and indeed, in this state, carbon dioxide is almost frozen. The cylinder is connected by a regulator. Sometimes it has a warmer in between, and this warmer helps to rather warm carbon dioxide before it gets into the insufflator. The tubing is connected at the back of the insufflator, and that allows carbon dioxide into the machine. And before any surgery, it is important that the surgeon always has to know how much carbon dioxide is in that cylinder at any given time. And it is also important that in any OR, you have to have a backup cylinder of carbon dioxide, so that in an event that the cylinder is empty, you can replace. Otherwise, if you don't have a backup, it can be disastrous, and that could be one of the reasons for conversion. The machine is switched on, and when it is switched on, it will detect if carbon dioxide is present. It makes several checks, and if it detects any error, it will alert you. Do not be surprised that the insufflator is always at the top of the trolley. The reason is the insufflator is the most intelligent equipment on this trolley. It gives the surgeon all the safety information about the pressure inside the abdomen. It gives you information about any leakages that you get at the trocars. You will be able to detect that you're leaking this much with the insufflator. And it will tell you when there is overpressure, and that is the reason why it has to sit at the top of the trolley, not at the bottom, because you have to keep communicating, looking at it. It gives several alarms, and you have to respect it. So when you switch on the insufflator, you realize that it has several modes. It has the pediatric mode for children and neonates. It has the high flow mode for adults. It has the bariatric. It also has the vessel harvest mode. So you can choose any of those modes by touch. This is the touch screen kind of gadget. And then it will display several parameters. Among the parameters displayed, we have the set flow pressure. You can adjust the set flow pressure to your benefits depending on the type of intervention you are going to do. It has the actual pressure. It has the set flow rate. You can set the flow or the rate at which carbon dioxide will flow into the patient. It has the total volume in liters. It also has the actual flow rate, and you can also change the modes. You can start or stop flow depending on when you need to use the insufflator. Now, there are 4 important parameters on this insufflator a surgeon needs to know and know very well. One of them is the set pressure. The set pressure is the pressure you instruct the machine to get into your abdomen. It is the desired pressure. It is the desired pneumoperitoneum pressure. And you can set it at 10, you can set it at any figure, but you need to know what is safe for your patient. If you are dealing with a neonate or children, then the pressure is determined by the weight of the child. If you are dealing with an adult, it is better to set the pressures between 12 and 15. If you work above 15, you are going to get very severe venous compromise, and most likely you can easily get a patient into a cardiac arrest. So it is better to set the pressures between 12 and 15. Those are the safe pressures for use during surgery. Sometimes people would set the set pressures to 20 during entry, and after they put in the primary trocar, they drop the pressures to lower safe pressures. The other parameter is the actual pressure. The actual pressure is detected by the machine as the pressure at the tip of either the varus or the tip of the trocar. And this is the pressure inside the abdomen. So at any given time, you can detect how much pressure you have inside the abdomen. Even when you're doing suctioning, or if you're leaking much and you collapse, the actual pressure inside the abdomen will display. When the patient wakes up, for example, and you have tensing of the anterior abdominal wall, the insufflator will start making noise over pressure. So you can detect that the patient is waking up even before the anesthetist is aware. The other parameter here is what you call the set flow rate. It is the rate at which you want your gas to flow. Initially, when we are starting varus insufflation, we set the flow rate at 1, simply because you want to flow slowly as much as possible, so that, for example, if the varus is in a wrong place, if the varus is in the inferior vena cava, if the varus is in any vessel, at 1 liter per minute, it is rare that you're going to get air embolism. So that is why we usually set 1 liter per minute. After you're sure that you're inside the correct space, you can increase the flow rate. Then you have the total amount of gas inside the abdomen in liters, that is the total volume used. At any given point or given time, the insufflator will tell you how much gas you've used. Usually, it is safer that at the end of varus insufflation, at entry, you should have used between 1.5 liters to about 6 liters. Why the variation is because you have different types of scenarios. Some patients are tall, others are short, others are young, others are old. You have the multiparous, the nulliparous, space-occupying lesions like masses, ascites, blood in ectopics. All these determine the volume of gas that will go into the abdomen. So that's why you have a variation of between 1.5 to 6 liters at the end of varus insufflation before you insert your primary trocar. At every hour of surgery, you should at least consume about 18 liters of gas. If you find that you've consumed more gas, then there's a problem, maybe leakage. So the 4 parameters we've seen are called the quadro-manometric indicators. The quadro-manometric indicators. The set pressure, the actual pressure, the set flow rate, and the total volume used are the quadro-manometric indicators. These indicators are very important for safety for every surgeon as you access the abdomen, because you keep looking at them and they will give you information where you are at any given time. Now we are going to demonstrate how to start insufflation. At the beginning of surgery, usually it is safer for most surgeons to enter the abdomen with the varus. Some surgeons use the Hasson's open method, others use the direct trocar entry, but you still find the varus as the safest method of entry in any abdomen. So, assuming this is the abdomen, I get the varus inside the abdomen, then you attach your tubing. Make sure the tubing is tight and there is no leakage. All right, so we set the pressure at 12 and the flow rate at 1 liter per minute, and then you start flow. Can you start flow? Let's go. So when you start flow, see what the insufflator says, overpressure, because we have closed the valve of the varus. The insufflator will warn you that you have overpressure. Let's open the valve. When you open the valve, you will start to realize that the abdomen goes up in pulses. Remember we said the insufflator has a safety mechanism of flowing in pulses to synchronize with diaphragmatic movements to avoid a vasovagal reaction. And it also gives you a chance, if you're in a wrong space, you don't have to drive in a lot of fluid. So if you keep looking, you will see that the set pressure is attained and the insufflator will stop flowing. The actual flow rate goes to 0 because the set pressure is attained. That means the insufflator has stopped flowing. If I release a bit, I create a leakage. When you create a leakage, the insufflator will continue to flow at 1 liter per minute to try and fill up the leakage. If you increase the leakage, rather the flow rate to 3, the insufflator is flowing at 3 liters per minute. If I leak, when it stops, when it detects that you have achieved your set pressure, it will go to 0. If you start leaking slowly, you realize that the actual flow rate also increases to 3. It means that you leak at the rate you flow. The leakage is at the rate you flow. If you stop the leakage, then the insufflator will quickly attain the desired pressure inside the abdomen and the flow rate will go to 0. So when you see that the actual flow rate is close to the set flow rate, it means you have a leakage and you must look for the leakage. Of course, it's difficult to attain a near 0 leakage, but at least you should have the set flow rate never equivalent to the actual flow rate. The other thing is, if there is overpressure, I'm going to create a scenario of overpressure. I will compress my abdomen. Pressures will go up, they'll go up, they'll go up, they'll go up, they'll go up. And then the insufflator will complain, overpressure, overpressure, overpressure. So the insufflator is able to detect that there is increased intra-abdominal pressure. Okay, when I release, it goes back to normal. If I continue compressing, creating overpressure, it will detect overpressure, overpressure, overpressure. And if you continue or you insist and do not sort the issue of pressure, the insufflator will take away the gas. It will drive the gas back. Usually it warns you, it beeps. If you do not do anything, it will suck the gas back into the insufflator to try and protect your patient. So those are the safety measures. So as we flow, assuming that I'm done with varus insufflation, you stop flow. Now I've inserted my trocar. You have the trocar inside the abdomen at the end of varus flow. Remember we said at the end of varus flow, you should have about between 1.5 to 6 liters of gas. We so far use 1.8 liters of gas, and that is okay. I'll connect the tubing. Every cannula has a valve to allow gas in. You start flow. I'm going to open the valve. Usually, let's go back, let's have a reset to 0. We stop flow. We let the gas out through the valve. There are two important quadromanometric parameters you're supposed to look at for safe entry. That is the actual pressure and the total volume. They should move in parallel. The actual pressure and the total volume should move in parallel. As you attain pressure inside the abdomen, the volume that goes inside the abdomen is parallel to the pressure. So let's start flow. Flow started. So if you realize you have a 0.1, the pressure starts to rise. The pressure and the volume will rise in tandem. They should move in parallel, slowly by slowly, until the actual pressure is attained. When you attain double figures so quickly, if within 1 minute, or rather within 3 to 4 minutes of insufflation, you have double figures, that means you're in a wrong space. I don't know if that makes sense. If in a very first few minutes of insufflation, you have attained double figures with a very low volume. For example, if my volume is 0.5 and already my preset actual pressure is in double figures, it basically means I'm in a wrong space. You stop insufflation and you restart again. Never doubt what the insufflator says. And for example, if I started flowing, I reset again, take the gas out, I go again, my trocar is in, I assume I'm in the right space. Start flow, please. Yes, thank you. Just 0.5 liters of gas have attained more than double figures. It means I'm either in the extraperitoneal space, I'm above the rectus, I'm within the muscle, I'm in the wrong space. So what you do, quickly stop, change position of your trocar, and restart. So the insufflator will usually quickly tell you where you are at any given time, communicate with it, and you should be able to have safe entry, and you should be safe inside the patient's abdomen. So this is how the insufflator works. This is how we adjust the figures, and if you have attained about 15 liters of gas, you always can increase to about 6 liters per minute of flow rate, or you can even increase more to about 10 if you are leaking more. The scenarios when you tend to leak more is 1, when you're doing suctioning; 2, if we have done a hysterectomy, we have opened the vault, a colpotomy. If you are retrieving any tissues via colpotomy, then you can leak at a very fast rate. And if you're leaking at a very fast rate, you can increase the flow rate. Otherwise, avoid increasing the flow rate unnecessarily, because the more you flow, the more you drive out intraperitoneal fluid throughout a leakage. Because if you are leaking at 6 liters per minute, for example, and more, then you're going to get bowel desiccation, you're going to get paralytic ileus in the post-op period of your patient. Because as carbon dioxide comes in from one pot, and you're leaking at 6 liters per minute, it keeps driving out the intra-abdominal fluid at the same rate. Eventually, you're going to get things like bowel desiccation, you're going to get hypothermia, because even heat escapes from the abdominal cavity. So hypothermia is one of the complications of leakage. The other complication of leakage is paralytic areas, and of course, when you leak, the abdomen collapses, the risk of bowel and visceral injuries are high, visibility is compromised. So try to avoid leakage by communicating with your insufflator. The use of this very important and integral component of minimal access surgery, and that's the insufflator. I, however, would wish that we discuss the physiology behind pneumoperitoneum. What is pneumoperitoneum? Pneumoperitoneum is the pressure inside the abdominal cavity. We need to understand as surgeons what happens when you drive carbon dioxide inside your patient. One of the things that happen is you compromise the intrathoracic pressure, because you make the diaphragm flat. Ventilation is compromised because the mechanical ventilation, or the ventilator, has to use a little bit more energy to try and inflate your lungs. So you compromise ventilation, and you also compromise venous return. Remember, the pressures inside the inferior vena cava is about 6 millimeters of mercury. So if you're flowing above 12 millimeters of set pressure on your insufflator, you're more likely going to compromise venous return by more than 10%. If you flow, or if you set pressures at more than 15, then the venous return will be compromised by about 20%. If you set pressures about 25, then you are going to most likely cause a cardiac arrest. And that is why most of these machines, the maximum set pressure you get is around 30. Because if you hit 30 and you work at that pressure for a sustained period of time, you are going to significantly compromise your venous return. Incidentally, the cardiac output will go down, tissue perfusion will be compromised, you get anuria, oliguria, and eventually you might end up with a cardiac arrest. So those are the issues that surround the physiology and the compromise of the hemodynamics that you get by introducing a pneumoperitoneum, and this must be understood by every minimal access surgeon. The other thing is when you introduce carbon dioxide, it diffuses into the tissues. When it gets into the tissues, it mixes with the plasma and you get carbonic acid. Carbonic acid will dissociate into hydrogen carbonate ions and hydrogen ions. These are excreted via the kidney and via the lungs. So that means that your patient has to have good renal function and good pulmonary function. Because if you cannot clear the hydrogen ions over time of operation, what happens is that you're going to get hypercarbia or high toxic carbon dioxide levels. And when you get into hypercarbia, you are most likely going to end up with acidosis. Acidosis will come up with all the challenges of acidosis. For example, you're going to get brain edema, and you get hyperkalemia, and hyperkalemia will change your rhythms on the ECG, and eventually you might end up getting seizures, and this is a bad, terrible time such incidents to occur in your OR. So how do we avoid these? One, you must set the correct pressures. Two, you should have a capnograph. A capnograph comes on the monitor, or most of the modern anesthesia machines have a capnograph to help you monitor the carbon dioxide in your patient. And your patient must have an ECG. That's a capnograph. The capnograph is an integral component of your surgery. Always have it every time you're doing laparoscopic surgery. And we usually aim at levels of less than 55. Anything more than 55 is toxic. So if you have persistent carbon dioxide levels at more than 55 on a capnograph, you have to alert your anesthetist. You can deflate the abdomen if hyperventilation fails. Because initially you hyperventilate the patient, and if the carbon dioxide will not reduce, then you have to consider increasing oxygen and deflating the abdomen, and perhaps get to what you call a laparoscopic rest break. A laparoscopic rest break is important for every surgery more than 2 hours. You get a rest break, it will help to reperfuse your tissues and of course improve on the safety of your surgery. So these are the complications that arise out of introducing a pneumoperitoneum into your patient. The other things that can happen, if air tracks in the wrong cavity, for example, the trocar comes out of your patient, then you can get air tracking under the skin, and you can get an emphysema. And an emphysema is common in the elderly patients. If not properly detected, you can have problems. The other complication that is really grave is air embolism. Air embolism can happen if you insufflated the wrong space, and that's why we usually start insufflation at 1 liter per minute. Always be sure you're in the correct space before increasing the flow rate. If you get air embolism, then there are maneuvers you have to do. You have to tilt the patient to the right side, and then you might also consider getting a central venous line to get the air out of the patient. Otherwise, it can be catastrophic, it can be so dramatic. So, if you understand the safe use of the insufflator and the dynamics of pneumoperitoneum, then you are going to have a safe surgery. It cannot go unnoticed or unsaid that the choice of your patients is everything to minimum access. So good planning is important. Choose the patients that are fit, choose patients that are hemodynamically stable, choose patients with less comorbidities, and those are the patients who will be able to tolerate these dynamics we've talked about, and those are the patients who will not less likely end up with complications. Otherwise, I hope you have a safe practice after this. Thank you very much for watching, and have a nice day.